afternoon, but good afternoon, everyone. I'm Peggy Datermeyer. I'd like to welcome you to our Lunch and Learn session today. We're very honored to have Dr. Luis Medina. He's a licensed clinical psychologist and cultural neuropsychologist who teaches at the University of Houston. I met him through some work I do with the medical school at the University of Houston, and I've found him fascinating. I told him this year that there isn't a time that I hear him speak that I don't learn something new. So he received his doctorate from the University of University of California at San Diego Joint Doctoral Program with San Diego State University. And he did his clinical residency in geropsychology at the West Los Angeles Veterans Affairs Medical Center, followed by a postdoctoral fellowship in adult clinical neuropsychology at the University of California, Colorado School of Medicine. As I said, he's on the faculty at the University of Houston, and please join me in welcoming him, and I can promise you'll learn something new.
Well, thank you so much for inviting me, and I'm happy to be here. And I understand we have a bit of a mixed audience, and so I do plan to have some time at the end for questions. And so I think my presentation is about 45 minutes or so, and then we'll have some time for questions. But thank you again for that presentation. I wouldn't be where I am without my wonderful team. We started the Collaborative on Aging Research and Multicultural Assessment at the University of Houston in 2018, and collaborate with a lot of folks, both at UH, within Houston, outside of Houston, and throughout the country and abroad. Here are just a few of our collaborators. And also, of course, I want to thank our team for the Engaging Communities of Hispanics Latinos for Aging Research Network, which is funded by the National Institutes of Health, particularly the National Institute on Aging. So we have a site here in Houston, and a site in Denver, and a site in Las Vegas. We're multidisciplinary. We work closely with community members, which is sort of the punchline of my presentation today, which is how to best address disparities in health across various different diagnoses and conditions. Really comes down to leveraging the strengths that we have when we sort of reach across the aisle and really build relationships with folks, especially folks in the community who are affected by these. So in terms of disclosures, I am a brain health disparities and equities researcher. A lot of my work is inspired by stuff that I saw in my own family. My grandmother passed away from Alzheimer's disease just over 12 years ago. And seeing what she and the family had to do in order to get a diagnosis and also for purposes of care have influenced the way that I think I view a lot of my work. And mind you, I went into this space before my grandmother even started showing signs of Alzheimer's disease. But other than that, I have no relevant disclosures. I've received funding from the Alzheimer's Association, the NIH, and also speaker fees. So I broke up this presentation into three main areas: a very quick primer on aging and dementia. I know that a lot of folks in this audience are probably familiar with these concepts, so I'll highlight a few things that I think are important to highlight here. And then the bulk of the presentation will be highlighting a lot of the different disparities that we see, and especially in aging populations. And then finish off with a bit on population health and where we hope that the field of health disparities is going towards. So here's just a slide that I tend to show folks that I teach on this idea of aging. And so with normal, typical aging, we see that from birth till about early adulthood, the brain sort of develops from its most primitive areas to its more sort of higher order areas. And of course, developmentally, this is necessary because we sort of need to know how to drink and eat before we learn how to navigate traffic in Houston. And so the areas that are very primitive and involved in things like eating and drinking develop much earlier than the areas that finally help us be able to navigate traffic. Inversely, after a certain point in life, and you kind of see this on the right-hand side, we see that some of the gray matter, white matter starts declining in terms of volume. And so we see after about middle age, this sort of peak that occurs and then this steady decline. In the lower left, you see kind of what this looks like for the full brain, showing the atrophy that occurs where our brains sort of shrink in size. But again, this is all part of normal, typical aging. It's what we expect. However, abnormal or pathological aging can occur. And so we refer to dementia as sort of this umbrella term that explains a combination of different symptoms and signs that together we call a dementia, but can be caused by a variety of things, similar to how a headache is conceptualized by the symptoms of what we understand to be a headache, but that a headache can be due to a lot of different things, whether it's from stress or dehydration or something more malignant going on. Dementia can be caused by a lot of different pathologies, with Alzheimer's disease being the most common form or the most common cause of dementia. But we also have things like vascular dementia, mixed dementia, Lewy body dementia, frontotemporal lobar degeneration, or FTLD, which leads to an FTD or frontotemporal dementia. Other related disorders include things like Huntington's disease, Parkinson's disease, that don't start off as a dementia but lead to a dementia syndrome, Wernicke-Korsakoff syndrome, HIV-associated neurocognitive disorder, and others. The understanding that we have with Alzheimer's disease is that typical AD is a dementia that involves memory loss with other declines in thinking abilities and daily function. It's the most prevalent, most common. Age is the biggest risk factor. At the time that I made this slide, it was a sixth leading cause. I checked recently, and I believe it's still hovering around that. But we are seeing some interesting trends in terms of the frequency of folks being diagnosed with this, and I'll get to that in a little bit later. The symptoms that we see with Alzheimer's disease parallel sort of the trajectory or the course that the disease seems to follow in the brain. And so the disease begins in parts of the brain that are primarily associated with memory and language abilities. And so we do see that those symptoms tend to be earlier in the course. However, as the disease progresses, we do see other areas and other thinking abilities become affected. People don't wake up with full-blown dementia from one night to the next. This does follow a progressive or insidious course with a gradual onset. And so we see that preceding dementia, folks may have or will be in a state known as mild cognitive impairment, where we can see changes in their thinking abilities, but individuals can still function independently in their day-to-day lives. We are understanding now that many folks that believe that they have subjective declines in their cognitive abilities that this may be a state that precedes mild cognitive impairment. And so what this means is that there are folks that are coming to the doctor, expressing significant concern with their memories. And we used to be able to test these folks and show that they didn't have any cognitive impairment, and we would send them home, and we would unfortunately refer to them as the worried well. These are folks that were doing well, but were really worried about their cognitive abilities. We are starting to see evidence, however, that these folks that are kind of noticing within themselves subjective cognitive decline, even in the absence of objective evidence that their cognition has declined, may actually have some underlying pathological changes relevant to Alzheimer's disease. And so we are now trying to collect better data and not send these folks away as if there's nothing going on with them. But we do like to monitor these folks. The changes related to Alzheimer's disease seem, however, to precede those first symptoms, even those subjective cognitive concerns, as much as even by decades, 10, 20, 30 years before the first symptoms arise. We do understand that there are changes in two of the main proteins or substances within the brain that we believe are associated with Alzheimer's disease, these being amyloid beta and tau. These are proteins that happen naturally in our bodies, and our bodies tend to sort of get rid of these at the end of the day when we're sleeping or throughout the day. But various processes change how our brain is either removing these or how these end up appearing in the brain, which unfortunately leads to structural changes, meaning that the neurons, the cells, the highways within our brains get disrupted, which then disrupts communication in the brain. And that's ultimately why we see a lot of these different behavioral symptoms. As I noted earlier, also typical Alzheimer's disease sort of begins in these areas, deep in the what's referred to as the mesial temporal cortex, where structures involved in memory abilities and language abilities typically are affected first before the disease spreads to these other areas. And I say typically because there are atypical forms of Alzheimer's disease, some that may, for instance, affect visual spatial abilities. So folks may actually have more difficulty navigating familiar areas. They may start bumping into walls more regularly, or difficulty sort of navigating even their home before we start seeing some of these memory problems. Other people can show with more of the language deficits before they start showing the memory deficits, and other people will have more of a what's referred to as a frontal form of Alzheimer's disease, where you may see some dysexecutive problems with planning, organizing, or even some behavioral issues. The Alzheimer's Association releases their facts and figures each year. Here are just a couple of things. I know it's a little bit small on the screen, but the first image is the percent change in selected causes of death of all ages between 2000 and 2021. And we do see this over 140% increase in the number of folks with Alzheimer's disease. We also see that the percent changes in emergency department visits is really high for Alzheimer's disease. And so not only are folks getting diagnosed with Alzheimer's disease, they're also having a lot of other things that happen that unfortunately lead them to have to present to the emergency room. Here we see the projected number of people the age 65 and older in the U.S. population with Alzheimer's disease, with projections going to 2060. This is broken up by aged groups. So ages 65 to 74 are in that teal color, 75 to 84 in the gold color, and ages 85 and over in the purple color. We do see that with each decade, the risk for getting diagnosed with Alzheimer's disease increases. And a lot of the work that's happening right now is trying to detect folks at the earliest stages so that we can slow down that process, given the implications that Alzheimer's disease, dementia has on the economy and on the financial status of a lot of families. And also, lastly, regarding reasons for hospitalizations of Alzheimer's disease, or persons living with Alzheimer's disease, these include things like syncope and fall and trauma. Falls are unfortunately a common concern that we have with older adults with or without dementia, but we do see that the majority of visits to the emergency room involve falls. Ischemic heart disease, gastrointestinal disease, pneumonia, and delirium or mental status changes are the subsequent items on this figure. The prevalence rates of dementia, however, do differ across various groups. And so here we'll start talking a bit about health disparities. And so we do see that the rates of dementia are generally highest in Hispanic Latin American individuals and Black African American individuals. Hispanic Latin American individuals are at about 50% greater risk, but because they make a larger part of the population, the prevalence rates appear higher here, while Black African American individuals are at twice the risk, or sort of 100% greater risk compared to non-Hispanic white individuals. This is important to note because ethno-racially, there are various factors that seem to be playing a role here, and we don't entirely understand all of the reasons why we see this increased risk, but it is problematic in several ways, and especially given that this is just based on the data we do have, while there's also data that suggests that we have a problem with even getting diagnoses. And so Black and Hispanic individuals are also at a higher risk of missed or delayed diagnosis. There's also implications here in terms of getting a timely diagnosis overall. And so, as I mentioned earlier, an early diagnosis may provide us as clinicians, as researchers, time to help the individual slow down the disease, but also in terms of future planning or advanced planning for families to actually be able to prepare for what's to come, so to speak, when it comes to individuals being diagnosed with dementia. And so, unfortunately, we are seeing that misdiagnosis or delayed diagnosis tends to affect certain communities more than others. Most of my work is with Hispanic Latin American individuals, and so we see here that this is the largest and one of the fastest growing groups of older adults in the United States. We see this increased risk for Alzheimer's disease, which is projected to lead to a 9-fold increase in the number of Hispanic Latin American individuals with Alzheimer's disease by the year 2060. We do see that folks, and sort of retrospectively, Hispanic Latin American older adults with Alzheimer's disease seem to have an earlier onset by roughly about 7 years compared to non-Hispanic whites, but often get a diagnosis later in life and are less likely to also be treated. And that these differences and these patterns that we're noticing are not explained by genetics. And so this is often referred to as this Hispanic Latino paradox of Alzheimer's disease, with this increased risk, yet living longer with the disease and not being explained by several factors. This is not just affected, or this is not just a pattern that we observe with Alzheimer's disease. There are other age-related disparities that we see in older adults, where minoritized communities, disadvantaged communities, historically excluded communities, ethno-racially diverse communities experience disparate rates of mental distress and mood disorders, polypharmacy and medication misuse, vision problems, which are now we're seeing may also be associated with increased risk for dementia. Hypertension and diabetes have been shown to be associated with risk for dementia, as well as obesity and mobility issues, which are also associated with disparate rates in disability and healthcare utilization. So I've mentioned these various groups that are affected by disparities, and so I'll take a quick sort of sidestep into sort of this biopsychological, social, and cultural model that we use to help us understand what's going on with the brain, And all of these things, of course, are connected and there's overlap between these, but a lot of Alzheimer's disease historically was viewed as a mental illness and as this psychological phenomenon. And so there's been historically this stigma that's associated with, of course, mental illness, as we know, but dementia is included in that. We now understand that there is this large biological aspect of understanding Alzheimer's disease that a lot of people actually still aren't completely sure about. And some folks don't understand, fully the genetics of it or how these various biological substances, at least in our current understanding of how these proteins work, how these are associated with the disease, but also how they're influenced by other factors. Socially, I mentioned, of course, the stigma that we perceive, but also there's so many societal factors that allow folks to either access care, not access care, or access the things that may help reduce risk or ultimately influence the increased risk. And of course, at the individual and community level, we also see some cultural factors, which has been a large part of my own research, because I believe that culture and cognition are tough to disaggregate. And the reason is that the brain develops through this process of exploration and decisions made with particular environment. And therefore, cognition is not just mediated by cultural factors, that cognition is cultural. And so therefore, it's really important for us to understand the context in which folks develop and they grow. And in the introduction, the term cultural neuropsychologist came up. And so what a neuropsychologist is just basically somebody who studies brain behavior relationships. A cultural neuropsychologist studies brain behavior relationships in context. And so that's the definition that we've been using in sort of this area, this niche area of study. But I really like this model summarized by Dr. Calsadias back in 2020, which he calls the P model of culture for us to help understand that context. And so context, as defined by culture, is a system of people, practices, and places, the processes between them in the acquisition or maintenance of power. So again, I'll say Dr. Calsadias defines culture as a system of people, practices, and places, the processes between them for the acquisition and maintenance of power. And so these various factors sort of influence cultural groups. And what we're seeing is that using that definition, there are many things that we can understand through that cultural lens, whether that's ethnicity or race or language, but also things like educational or vocational cultures, the regional cultures that we see even here within the United States, sociopolitical cultures, religious or military cultures, et cetera. All of these things have an influence on a variety of things that we know are associated with brain health. Within our own work, when examining culture, we see that cultural factors are associated with how people perform on a variety of tests. We've seen that various algorithms used to predict when somebody will present with cognitive decline related to dementia differ based on whether or not they account for culture, where algorithms that do account for culture have greater measurement precision. We do see that at autopsy, folks with confirmed Alzheimer's disease in their brains performed differently on cognitive tests depending on their ethno-racial self-identity. And we've also seen that across ethnic groups that some of these tests that we believe are associated with certain structures of the brain or certain functions in the brain relate differently to those processes depending on their ethno-racial identity. So all of this to say that we, from a health disparities perspective, are trying to account for a lot of things. And so in 2015, the NIH and NIA specifically, the National Institute on Aging, released their disparities research framework for us to better conceptualize that across the life course and across these various fundamental factors, we need to understand these various levels of biological, psychological, behavioral, social, cultural, and environmental factors to better understand Alzheimer's disease and other aging conditions. And so I highlight that, one of the things that is really interesting whenever I give talks out in the community is that a lot of folks think we as scientists fully understand and know what Alzheimer's disease is. But a lot of us would be out of a job if that were true. We wouldn't be doing what we're doing because the fact is that we still don't know. There are many things that we don't know. Now, I will highlight a couple of things coming up shortly as to why we still don't know. And part of it comes back to our understanding of these various factors shown here in that framework. I will, since the talk is from Neurons to Nations, let's talk a little bit about the global perspective on some of these things. Here I show the United Nations Development Program schema for calculating what's referred to as the Human Development Index. And so there are various dimensions included in this calculation: longevity and health, knowledge, and the standard of living, which are measured through the nation's longevity and health, through their schooling expected versus their actual mean schooling, and also the per capita expenditure of the economy for that nation. So longevity and health, the knowledge and education of the folks, the standard of living based on how much that nation is spending. These are interesting factors for us to keep in mind here in the United States, because as you can see here, we have a lot of disparities based on each of those factors. And so high school diploma, unemployment rates, here we also see the percentage of the population living in poverty, and so social determinants of health, related to things like education and expenditures, socioeconomic factors that are then associated with health factors, as I'll show you in a couple slides. So at the global level, here is, if we take all of these nations, we calculate that Human Development Index, you see that the majority of the nations fall along this color-coded ranking system, where the United States in 2018 had an HDI of 0.92, and so we were at that top tier of HDI in that dark green. Interestingly, some researchers wanted to point out the fact that this is kind of an oversimplification of what's happening within a nation. So between nations, HDI highlights certain things, but they came up with this disparities adjusted or inequality adjusted HDI. And what we see here is that when you look at within countries, the folks that are living longer, that are contributing to the economic expenditures, and the folks getting that education, that there is more inequality represented, which brings many countries down on that HDI scale. And so you see that the US goes from 0.92 to 0.797, a whole 3 different colors or shades of green based on the inequality adjusted. We see that the US spends a lot of money on health and healthcare. Healthcare spending is one of the highest that we see in the world, but unfortunately doesn't mean that our folks are any healthier. And in some cases, some folks argue that we're spending twice as much and our folks are actually sicker here in the United States compared to other high-income countries in the world. I showed those maps earlier with those differences and disparities in socioeconomic and educational attainment. Here we see a different kind of map, which highlights some of the rates of various different health conditions. On the upper left, we see the stroke death rates with the stroke belt area being a very dense color. We also see heart disease differs across the country. We see the prevalence of obesity of all races differ. The prevalence of hypertension differs. The prevalence of diabetes differs, et cetera. All of these things that are associated with brain health that sort of weaken many of the structures within our brains, allowing for an increased risk for Alzheimer's disease. And as you can see, the pattern of risk for dementia follows a similar color scheme to those previous maps. When we look at this by within states, within counties, we also do see, however, that ethno-racial groups differ within those areas in terms of their prevalence. So we're seeing sort of disparities, even sort of ethno-racial disparities within regional disparities of these conditions. Part of what I highlighted too is in terms of who are we missing? And so a lot of the research, unfortunately, has excluded a lot of folks, even though they are at increased risk for various conditions, from the research from a variety of barriers that exist within the research enterprise. And so I'm just using here the example of Hispanic Latin American individuals living in the US, comprising 18% of the population as of 2018. These were the leading causes of death for Hispanic Latin American individuals. You see cancer, heart disease, accidents such as motor vehicle accidents and other accidents, cerebrovascular events, diabetes, and Alzheimer's disease, rounding out your top 6 causes of death. However, when we look at the National Institutes of Health and their reporting of who is participating in research, who is enrolled and included in research, we see that the median percent of these research samples never hits close to that 18%. So when we are trying to sort of synthesize research data, we have to understand that the samples may not be representative of the populations that we're trying to work with, or that we're trying to target. This 2020 article was very popular and was circulated very extensively because of the amount of work that went into this huge systematic review and meta-analysis. They looked at both randomized controlled trials as well as sort of these prospective studies, observational studies, looking across the lifespan at these various risk factors that happen at different ages that may be associated with brain health. But when, again, we look further in that same article, we see that the majority of the research that's being reported comes from certain parts of the world that, again, may not be representative of all of the population that we're trying to serve. Interestingly, as a neuropsychologist, my colleague and I wanted to see how some of this relates to our work within the field of neuropsychology specifically. And so we looked at a variety of demographic variables that we have seen and based on previous literature. I have here a couple of papers and reviews that show how things like age, education, gender, race, ethnicity, acculturation, language, and socioeconomic status seem to be associated with performance on cognitive testing. And so what we did is we examined the top journals in neuropsychology to see how often researchers reported these demographic variables. And we compared this to a similar study that was done 15 years prior to kind of see where we are sort of in the state of the science. And so what I show here are sort of the results of that. We saw that Almost always, research samples are described in terms of their age, their education, and their gender. Less than 40% of the time do we know what the ethno-racial composition is of those research samples. And unfortunately, we rarely know what the acculturative level or a socioeconomic status level or the language level is. And I know that this is a mixed audience, but if I were to present this to neuropsychologists, one of the biggest concerns here is that 20.6 of the time is when we know what language people are even being tested in. And so if I were to take all of you in this room or on the Zoom call to get testing done, and I said to you, we're going to do all of the testing in French, even if you don't speak French, and you performed poorly on these measures that are in French, how well do you think you would perform? And how accurate would our measurement be? Not very accurate, right? And so 4 out of 5 times, we don't even know what language people are speaking in our neuropsych studies. This is all against the backdrop of lots of changing demographics. We see that there's a rising trend of individuals in the US who speak a language other than English. Again, Hispanic, Latin American individuals are at largest and fastest growing. But we also see changes in socioeconomic and educational attainment, a decline in folks living below the poverty level, the folks that are getting less than a high school education has been declining because more and more folks are getting more than a high school education. But despite these changes, we published this paper last year. We're noticing that most of the research done in Alzheimer's disease, the folks that are included in those research samples are also not representative of their sort of counterparts in society or in the communities. Here is an example we show using a color-coded shape system that even the non-Hispanic Black individuals within the National Alzheimer's Coordinating Center data, one of the largest data sets we have for understanding Alzheimer's disease here in the US, funded by the NIH, the folks in that sample are not representative in education, age, or various other symptoms compared to what we would expect of other older adult non-Hispanic Black individuals living in the United States. All of this to say that there's a lot of work that needs to be done. I do a lot of work with trying to understand some of these recruitment disparities, which is why I have several slides on this. But every individual who participates in research, or even every individual who participates in care services, has to balance or weigh various benefits and burdens that may come from that. Folks, sometimes have to decide if they're putting food on the table or paying for some kind of clinical service. Are they going to work, or are they taking time off work to participate in a research study? There are various layers within the research recruitment ecosystem as well that provides unfortunate barriers to participation. At the levels between the individual and the research team, for instance, research team members that may not speak the same language or understand the individual's cultural background, institutional barriers and systemic barriers that make it very challenging for folks to participate. And so to this end, we, with the work that we've been doing, we've done extensive research or review of the literature on this topic of recruitment disparities. And we pretty much identified sort of what we refer now to as a three-legged stool for a lot of our work, which is ultimately we need to continue building trust, improving communication, and we as researchers and clinicians and providers developing cultural competency and updating this to actually cultural humility. That's an ongoing process for us to better engage with communities raise awareness of these various health risks and health conditions, these disparities, and also ways for us to address these issues. And one of the things that we have truly learned throughout this process is that all of these are vital steps for inclusion. However, including diverse voices from the community at each of these steps is truly vital for equity. And so we are currently working to really meet communities where they are. Whether we've done these events at community health centers, sort of bringing science and research and care out to the streets. Last Friday, we took our mobile health unit out to a community center. For the first time, we were very excited to be able to do this, but actually doing brain health screenings out in the community where we're not asking folks to come all the way to the university or the academic medical center. We're going to them. Working closely with community health workers. This is something that's that our community is telling us we need to do. And so building those relationships over the last several years has been really fruitful, and ultimately trying to increase access for a lot of these things. And I'm going to start wrapping up very shortly, but I tell a lot of my students that so much of my training, my education, my research keeps coming back to these two models that I learned as a college undergraduate. And one is Maslow's hierarchy of needs. And Becky's laughing because it's just so pervasive across anything that we're studying, that people's basic physiological and safety needs are necessary before we could even sometimes do the work that we want to do. Yeah, as I mentioned, if somebody is having trouble putting food on their table, it's hard for them to commit to or pay money or time to partake in some of our services or programs or part of the research enterprise. People don't feel safe, right? People don't feel fulfilled in these other areas of life. It's hard for us to tell them, hey, you're at increased risk for this other stuff, and so on. And so being really aware of these social determinants and structural determinants that are really affecting the life of the individual for us to be able to better address their needs. And the other model that I keep coming back to is Brockenbrenner's social ecosystem. And so understanding that the individual doesn't exist within a vacuum. This individual exists within a system with their family, their school, their peers, their church group, their neighborhood area. This extends further out to these communities, these neighborhoods, and ultimately to the system of the society in which they live in, the socio-political climate, the cultural values and ideologies and attitudes, and all of this evolves over time. And so for us to understand the individual's hierarchy of needs and also the context in which that person resides. And so population health, I got this idea of this analogy from a presentation on population health that I attended some years ago, where unfortunately the health system now is really trying to just mop up the water instead of turning off the faucet. Where we spend so much time, money, and effort in trying to help people who are already sick, rather than putting a lot of effort into trying to get people to prevent sickness. And so primary prevention, early intervention, and treatment are ways for us to try to conceptualize this, where prevention is aimed at preventing the problem from occurring in the first place, versus intervention, which is the treatment that occurs after the problem has arisen. And unfortunately, in the U.S., we, quote, tend to be reactive versus proactive. We often wait for a disaster or problem to occur rather than spending effort and money on preventing it from happening in the first place. We're noticing that things like educational attainment, vocational training, sleep, exercise, diet, these things that we hear about all the time actually do have a big impact on our health. And if we want to live longer, healthier lives, these are targetable, modifiable factors that we can incorporate into our treatment models, our research models, and so forth. And so this population healthcare delivery model highlights that primary and secondary prevention can actually be done in order to reduce the risk that the person will get the disease. And then once the person has the disease, perhaps we can do some tertiary prevention before we have to get into treatment. So you see this in some of the medical visits that you may attend, where we're trying to see people who are pre-hypertensive or pre-diabetes in order for us to be able to prevent them from getting over a threshold. So the who, the what, and the how, this is a complex problem with many folks involved. And so we see those models of Brockenbrenner and Maslow's playing out at a larger level when we think about populations. So I've mentioned a lot of words, inequality, equality, equity, and justice, and really how so much needs to be done for us to help customize tools and identify and address inequalities through this equity framework, but ultimately that the number of layers involved in how people are healthy ends up being a justice issue. And so really working on fixing systems and structures to offer equal access to both tools and opportunities for individuals, and really maintaining that cultural lens when working with our diverse communities. And so I highlight here that it's a beautiful world, and that when we only focus on one or two aspects of things, we may miss out on the full richness of that tapestry that's in front of us. And so for us to understand not just the individual's biopsychological, social, and cultural layers, but ultimately all of these things that are allowing this person to live and thrive within a particular context will need to be appreciated. So thank you so much again for your invitation, and I'm happy to answer questions.
All right. Well, thank you so much for I have to tell you, there were a couple of moments in there where, and I, my title here is Community Aging Specialist. So I dare say I have a certain level of competence in some of the areas that you discussed. But when it comes to the disparities in particular, that was a oh boy kind of moment. And I think before we even get to the chat, I'm curious, beyond the fact that you're based at the University of Houston and certainly surrounded by a fine team that you have collaborated with over the years, you're also at a public university in Texas. And I am curious as to how the current climate in which you operate is allowing your group, your collaborative, to go ahead and to not just work on further transparency of these issues, but in addressing them from the base of a public university, which my daughter is going to, by the way. So I'm a fan of U of H. Go Cougs. But
I love the elephant in the room, right? Let's just jump to it. This is something that did come cross my mind definitely as the legislation was being discussed. And so for those not familiar with the University of Houston as a public institution, it has to follow and abide by certain rules of the state of Texas. And so it's referred to as a DEI bill, and I can't remember what the SB number is, but that bill, unfortunately, removed funding for many of the DEI efforts at various, well, pretty much all the public institutions. And so Our legal team at the university last August was working very, very rapidly to try to at least make sure that we were compliant by a certain date, which I believe was September 1st. And so one of the things that we've had multiple discussions about this is that bill is targeting monies from the state of Texas towards public institutions and what that money can be used for from a staffing perspective. Mm-hmm. And so they've made it clear to us that from an education perspective and from a research perspective that we would not be affected. That is what we were told. So what's nice is that so much of this work is funded by NIH, and so we're doing this following scientific frameworks, and it's often what I tell my students is at the end of the day, I'm just showing you the research. Here's the science, and the nice thing about science is that it changes. We correct it when we find things that are wrong, but we're seeing more and more evidence that these frameworks are playing a role in what the patterns that we're seeing and so forth. And so we haven't had any issues, knock on wood, so far. It's been actually, UH has been extremely welcoming of this line of research. The new medical school is very interested in population health and there's a huge need even at the primary care setting. And so one of the things that Peggy and I do, Dr. Dedemeyer, and I do at the medical school is to teach folks about how to do culturally humble and competent primary care of older adults. And so I've been very fortunate at the University of Houston that the stuff that's happening at the state level hasn't tainted the science that we're trying to show both in our coursework and in our research. I do have colleagues in other states who are experiencing different things, but we've been very fortunate here.
Yeah, I mean, and for those of you who have the question, because I'm thinking back on the definitions, especially of equity and justice, and the illustrations that you used along the way in terms of achieving greater cultural humility, greater cultural competence, and therefore greater cultural representation in the studies that will in turn provide us with more accurate detail as to who needs particular services and when, whether it's on a preventative level or when necessary on a reactive level. Whether that is countercultural or not, I guess depends on the state in which you live. But it is a reality that we do wrestle with regardless of our locale, because very often people will not feel that they can turn immediately to medical resources if they don't feel in turn that those medical resources proverbially or literally speak your language. And yet terms like equity and justice, I know are targeted on a level that does impact the public collegiate sector in this state and other states, as you've mentioned. But I think it is important to go ahead and to highlight that what you are describing are terms of professional art that are absolutely necessary in order to get real work done. So I applaud the continued efforts that you are doing, not just to do what you have been doing before politics entered and remained in the arena, but beyond that, to go ahead and to help educate people as to the difference between a political position and a scientific position, where both happen to use terms that, depending on the circumstance, may mean very different things.
Very much so. Thank you for highlighting that. And yeah, as you were speaking, I kept thinking about some of my colleagues who are in epidemiology or economics, where these issues that I raised are of very big interest to them because of the systemic implications that they have.
Yeah.
Right. One person being sick is often viewed as just that individual. But when we talk about Alzheimer's disease, right, that individual needs to be taken care of. Who's taking care of that individual, whether it's an informal family caregiver, a spousal caregiver, an official formal paid caregiver, et cetera. And then the implications of sort of, I don't like using this term, the burden on the system when more and more folks have public health concerns and we get into these public health crises. And so when folks stop thinking about this disease affects this one person and starts thinking about how this disease affects us as a community, as a nation, as a population, I think that changes things for a lot of folks, and it becomes hopefully less political. But my colleagues in epidemiology are showing these at larger numbers, are showing the economists are showing the economic strain that is caused by these public health concerns. And ultimately, we hope that the right people are listening so that they can kind of let us work and change things.
And the question that we have here in the chat is, I think, a great example of how both the individual and the social remain in this fugue state until we have made conscious choices to go ahead and to, first of all, fully see and hear people based on not just where they were raised, but also what are the religious and cultural and social and ethical linchpins of their existence. And for Kathy, who here in the text describes her mother-in-law being diagnosed at the age of 84 last year with mild cognitive impairment, refusing treatment and thinking that it's normal aging. And then it's a very important question. What is the progression pace of this diagnosis of mild cognitive impairment from a year ago? And the on one foot answer is, we have no idea, which is a terrible thing to have to say to anybody who is dealing with uncertainty when they observe a loved one who is going through a neurological change. And yet, if we had the cultural humility to go ahead and to say, is it possible that based on your mother-in-law's age, ethnicity, socioeconomic background, how she views her role, if any, in a medical conversation, to what extent is she actually denying her own autonomy and in need of assistance in championing her autonomy, her own voice, when it comes to the questions that need to be asked in order to get to a reasoned answer to a progression pace for such a diagnosis, which again, if we knew fully, we'd be discussing this with far different sets of data than we currently have.
Very much true. I totally agree with that. It is tough to pinpoint any of this. There is some really great research on resistance and resilience. And so for somebody at the mild cognitive impairment stage, as you mentioned, depending on these various factors, we might predict somewhat without great accuracy what that progression could look like. But there are things that we try to do to continue to sort of help the individual from rapid decline. And so an MCI, not everybody with MCI converts to a dementia. There are some folks where their MCI is not due to Alzheimer's disease. And there are other folks that may stay in an MCI stage for quite some time before they decline. And so to that point, I would recommend, of course, monitoring that, but also continuing to live, with your loved one. Things like diet and exercise and sleep quality and quality of life and many other factors like stress management and
Not getting UTIs.
and reducing the risk for delirium, right? So like a UTI or other kinds of infections can increase one's risk for delirium. where they may need to go to the emergency room and be seen, but then unfortunately that can put them at increased risk for even a quicker decline.
And so unfortunately, we all know that whether one goes to urgent care, which usually is the case if you have adequate insurance, or more likely if insurance is a factor in your decision to receive medical assistance, you're looking at an ER. You're likely to experience not just the secondary trauma of being in an overtaxed setting, but depending on the attention that you can receive, timely and focused, your prognosis will vary. Regardless of whether you are merely observed, whether you are treated and let home, or whether you are admitted. And then, of course, the likelihood of you dealing with secondary factors in engaging and taxing your system are of course going to be exponentially higher. The sad part of this is that our medical system, as you rightly pointed out, is a little too busy mopping up the mess and hasn't yet got to the plumbing. But I want to go ahead and make sure that we end on an optimistic note rather than one in which only challenges are faced. So one final question for you, which is, what's the best day that you've had this year working in your field with your team at your university?
Well, there are multiple great days. I don't know if I can rank the best one, but it's truly been being out in the community, sharing with folks. And so, like I mentioned last Friday, being able to provide a service at no cost to people who benefit from it, and being able to give them, compassionate, culturally responsive care, because there are so many places that folks can go, so many things that people could be doing with their time, that they're taking time to learn from us and for us to learn from them and just share with us. And to me, I think that flips a lot of the ivory tower academia model upside down, where it's less about we know all of these things and you need to come to us through these gates to learn. But for us to be able to just sit with folks, whether it's they're sharing with us some bad news or sharing with us some good news and everything in between, to me that gives that's in line with like how I find purpose in life.
And with furthering your purpose and hopefully by osmosis, each of our own purposes in life, we want to thank you so much, Dr. Medina, for spending your time with us here at the Hope and Healing Center and Institute this afternoon. And to all of you who have been watching live, whether in person or via Zoom, or who have been listening to or watching the recording and following the slides, which will be distributed to all registrants in the next few days. We hope that the rest of your week is filled with meaning, and that you all are treated as kindly and as gently as possible. Thank you again, everyone, and you all take care.
Thank you.